Hello, welcome to Aging Well in America. Every day, 10,000 people in the United States turn 65 years old. 5.5 million people are the age of 85 or older. By the year 2050, which isn't all that far from now, that number grows to 20. 20 million people will be aged 85 or older. Are we ready? Is America ready? There's so much good work going on right here in our own community and around the country. And we have with us today one of those people who's doing some of that good work, Deborah Johnson from Care Insight. Hi, Deborah. Thank you for coming over today.
I'm thrilled to be here, Anne Marie.
Yeah. You do a very, very special but not well-known practice.
Yes.
As a registered nurse and a certified dementia specialist. You have a care management company called Care Insight, and you manage people's care for their family or in coordination with their family. Mm-hmm. Tell us a little bit about what that means and what does that look like for a family calling you for some assistance with their
I'm
parent.
thrilled to be able to share this because what we hear, Anne Marie, more often than not is how come I didn't know about you when my mom was sick or
Mm-hmm.
when my husband was ill. So I'm excited to share this.
Great.
So care management is it's an advanced way of delivering nursing services.
Okay.
So we all know about the nurse in the hospital.
Yes.
And we know about the discharge planner, sometimes called a case manager, that discharges you from the hospital. But how we consider ourselves are external, meaning we're outside of a hospital or a facility, mm-hmm. and we're community care managers,
okay.
which means we can float between working with you in your home, to a nursing home, to a hospital, through the ER, back to maybe a retirement facility, mm-hmm. back to home. Wherever you're at, we can follow you.
Okay.
So we're sort of attached at the hip, so mm-hmm. to speak.
Mm-hmm.
So if I get a phone call from a family member, and this is pretty typical, their mother, mm-hmm. which is usually someone's grandmother also, mm-hmm. is not responding to treatment like they expected, and the doctors are throwing diagnoses at them that the family's not really sure what it means, mm-hmm. or grandma's consistently telling them, I'm just fine, mm-hmm. don't worry about it, but they see a little spiraling downward and they're confused. They may have suggestions for mother, and sometimes as family members, mm-hmm. my father does not listen to me like he does to his doctor, right?
Right, exactly.
And as a daughter, I don't have the pull that I do as an outside person coming into maybe your home and talking to your mother. I've seen it before when we sit around the table, we're talking about what can I do for you? And I have a suggestion, and that grandmother pokes the daughter and says, how come you never said that? And I look at her eyes, and she's rolling them, and I know what she's thinking. I told you 100 times, but you didn't hear me.
Right.
Happens in every family, right? It's nothing unusual.
Right. So
people call us to come in to take a look at the medical as well as the social mm-hmm. issues around a person who's disabled. And most of the people we work with are geriatric population. Mm-hmm. And we are paid for by the family because mm-hmm. unfortunately Medicare, Medicaid, nothing pays for our services except maybe long-term insurance and occasionally a disability policy, but not often.
Yeah.
So it's usually a family calling us in saying, please, I throw up my hands, or what can I do? We've got a problem. So we sit around the table with, hopefully we have time to do this. They're not in an emergency room mm-hmm. right now. Mm-hmm. We sit around the table and I meet, or one of my case managers meets the person we're going to be working with. The family members bring their issues to the table, and we kind of toss it around and find out what's most important to you. Mm-hmm. Is it staying independent in your home? Is it understanding diagnosis? Is it making sure I'm not on too many medications? Do I really need this surgery? Whatever the mm-hmm. issues are, the prominent ones, those are the ones that we work with. And we'll go home after meeting the family and draw up an evaluation of how they're doing physically and have some recommendations. Come back, talk to the family, and the family may say, thank you for your evaluation, that's all I needed, and we'll carry on with the recommendations. or they may say, you take the top 3, I'm going to take the bottom 3, or please handle it. You know, it's real important it gets done, and I'd like you to handle it. So one of many ways. You've
mentioned a real interesting one there that I hadn't heard before. Do I need the surgery?
Yes.
Do I need this treatment? So what, your care managers are primarily RNs?
Yes,
and
they are.
Social workers as well? Or?
We don't have social workers right now. We work only with RNs with 15 years or more experience in nursing.
Okay, so the nurse then, the RN who is hired by the family to be their care manager, would then do what? Accompany the family and the client to a doctor's visit appointment and have a direct conversation, and then help maybe to translate some of the medical discussion?
Absolutely.
Yeah.
And we kind of figure that out around the table. If people want to keep the hours or the cost of our services low, they may just want us to stop in every once in a while and fill us in on what's happening in those doctor's appointments. Or they may say, look, please go with her or him to those doctor's appointments. Sit in the background, but listen to what's happening and add anything that you think needs to be added. So we're really partners with that doctor, and we're partners with the client. So we can do a little bit of care if that's what the family wants, or really make sure that we're there in emergency room visit. See, we can actually go into the bedside and actually look through your chart with your permission, so we can coordinate the doctors while they're in the hospital and your discharge planner to make sure she's not putting you over here because she thinks it's good. We're really going according to your wishes.
Good. That's amazing, because so many family members try to do that, and often they just don't get the results that they're looking for in the hospital.
Yes.
So what might the evaluation or the roadmap look like if they're calling you because mom might need, they're thinking about moving mom, or it's time for some help in the home. I'm thinking that there are probably services out there that you know about that the family hasn't even thought about.
Oh, absolutely.
What are some of, and you might coordinate some of those services or give them a list. Like you said, you could do as much of it or as little as they'd like.
Absolutely, because this is where we live as case managers. We go to all the networking, we're at all the seniors exhibits, we go to all the scan meetings. We're really filled with all the information that's around, so that when we have a client that needs in-home health, we may call Anne Marie with BrightStar and give them a list of people they can call. Or if they need transportation, we have an idea of the different transportation issues around, because that's what we do. We're not engineers, and we're not bankers. This is where, this is the realm in which we live. So our value to the family is a lot of resources. So they're not picking up the phone book and saying, okay, eeny, meeny, miny, mo, or calling their girlfriend saying, who do you know? But they really have a personal relationship with a person who we can try one provider. If it doesn't work, we've got a lot of people behind that we can use. So our main goal is the family and the client's happy. We give them all the services that they qualify for or want, and we have a background of history in case something comes up. We can pull that information in. So yes, we don't provide the home care, we don't provide the transportation, we don't provide the pharmacy, etc. We are separate, independent care managers, so that we can use our network and put the right provider in place. We're not obligated to use our own provider because it's going to come out of our pocket. We can use what's best for the client.
Right. Okay.
Yeah.
So when you say you might recommend or even set up some of those appointments,
absolutely,
you might be the conduit between the home care agency and the family, or between the pharmacist and the family. Is that correct?
Absolutely.
You might be the one to make that initial phone call and get them together.
Yeah, like one of the problems we sometimes look at is that the elderly have been given medications from their different providers. Maybe they had a hip fracture and they still have pain from that. And maybe they have an internist that they're working with. And maybe they have diabetes and they have all these doctors working with them. They end up with 12 medicines and they're not sure if they're appropriate. We can call their pharmacist, go over it. We can call the physicians and make sure that we're down to the minimum amount to produce the best results. So we can intervene so that they don't have to. I can, as a registered nurse, get on the phone, talk to your doctor, and get orders, take them down, and then implement the orders, which saves you a trip to the doctor, a trip of explaining what's going on, and saves you money and time.
Sure, sure. Give us, do you have an anecdote or two? A story that you're maybe especially proud of?
Oh, yeah.
I bet you do have a few of them.
Yeah. I got a call, and there was this individual. He's a younger man. He was 55 years old. He had run a major company. And he was in a nursing home, and they were going to kick him out of the nursing home, and the family that lived in Texas, Chicago, and Nepal was overwhelmed. What are we going to do? They're going to kick us out. They're saying there's no more funding. We'll pay privately, but the nursing home was not interested in paying privately. So they pulled me in and said, help us out. So we went over lots of options for him, and he had had a massive stroke, so he was no longer able to work at his business. So what we arranged for him, he was actually from Iran. And what I knew out of my networking is there was a group home in the Troy area run by an individual who's Iranian, who spoke the language that the wife, who didn't speak English, spoke. And all the family spoke.
Wow.
And so he had a good idea of the social issues they were dealing with, too, much more than I did. So we moved him into that facility after the family was thrilled that they got to talk to him. And now he's still there in that facility. He's progressed a lot because we got physical therapy and occupational therapy and speech therapy in there. And he is now standing on his own, which he wasn't before, transferring by himself. And he's doing really well, a lot better than we thought was possible. And the family has someone they can get on the phone with and have a conversation in their own language, that they don't have to train that person, and this is the way we do things, right? So I mean, I love doing things like that. That's made a big difference in his life.
Yeah, I'm sure it has. How? What's the average length of stay a family might have with you? Might stay with one of your managers?
Average length would be anywhere from 2 to 5 years, usually. We love to be pulled in early so that the family says, Mom's starting to spiral downhill. I don't know if it's Alzheimer's or dementia. I don't know if we're going to need anything in the future, but would you come in and let us know so we can do an evaluation? Because if we do an evaluation early on, we can work our preventative work. That's what nurses do. We prevent things, right? So we look at the medicines and take away, with the doctor's permission, the ones that don't work. And we make safety in the home so they don't fall. And we work with the communication with the doctor so that their symptoms are communicated clearly to the doctor so they can be treated appropriately. And we're there in the ER because hospitals can be a dangerous place for people, especially when they don't have clear communication. And we're there to prevent things. So we can prevent and increase people's safety in their home and help them stay at home longer, usually, if we come in early when people are just looking to see, let me talk to you about Mom and let's see what things we can do.
What area do you serve, Deborah? We
have 10 care managers, and they're throughout Michigan. So maybe the Tri-County area, Macomb, Wayne County, and Oakland are the main areas we're in right now. But if they needed care, my network or my care managers themselves would actually be able to move them.
Great.
Care for them.
Here on the screen is your the cover of your brochure with your telephone number. I'll read it out. It's sometimes a little difficult to see. It's in Michigan, 248-331-1000. 248-331-1000. And you've got a website, careinsight.net. Careinsight.net. Your website is wonderful. It's very interactive. It's very it's has all of the answers so many questions, and there's some stats on there that I didn't even realize. And this is about family caregivers themselves. 40 to 70% of family caregivers have symptoms of depression. 40 to 70, and that alone can help can cause somebody to have such a negative impact on their own lives with regard to their, not only their well-being, but their employment, their own personal family relationships. I know when I was caring for my elderly parents, I'm sure I was within that statistic.
Mm-hmm.
It takes its toll caring for an elderly parent, unlike anything else. What is it about that? You've
Well, we're
worked this so
switching
long.
roles. You know,
Yeah.
we're going from being the daughter who, you know, is daddy's girl, and we always looked up to him. He was, in my case, he was a Marine. He was an incredible
Yeah.
human being. I always looked up to him, to seeing him, you know, his memory going down. And I could see what I think, personally, what I saw that caused me grief and probably some depression during that period was I saw my life story disappearing in his eyes. And it's so sad to see that go. So you're so involved, as opposed to being a nurse and taking care of your mother or father.
Right.
When I'm taking care of my dad's a whole lot of
Yeah,
interaction
and
that
you're a
goes on.
daughter. Yeah.
And that's where the depression comes in. And there's absolutely nothing wrong with it.
It's so
Our job is
normal.
to care for the caregiver, though.
That's right.
Because if something happens to you and you get ill, which happens a lot of times with caregivers, then your mother or father are really in trouble.
Right.
Because we can manage their medical care, but they need someone like you who knows them intimately, to love them, to care for them as your father and mother. There's nothing more healing than that.
Right. I read somewhere, Deborah, that one of the foremost reasons that elderly move into nursing homes, and this is those who do not want to move to an assisted living but move somewhere out of their own home, is because their family caregiver got ill and could no longer keep them home.
Yes. A lot of our role is taking care of the caregiver. I remember when my father was ill, we had a hospice nurse in, and I was doing the case management in my family. I got the Google map up, and I was scheduling us all and scheduling the nurses and doing all that. And I found that I had an appointment that I wasn't going to keep. And the hospice nurse was within hearing range, and I said, I'm not going to go for my massage. I'm going to cancel it. And she ran from the bedroom into the living room and says, no, you must have a massage. And that gave me permission.
Yes.
To take a deep breath and take time for myself. And we need that outside information saying it's okay, and not only okay, it's critical that you take care of yourself.
I have a similar story, but it sort of turned out the opposite, because I didn't have a care manager like you giving me permission, but it was Thanksgiving a couple of years ago. My mom was living with me. I was having 40-some people over for Thanksgiving, and believe it or not, Thanksgiving morning, everything was done. So I decided I'm going to a yoga class. And my sister, who was going to come over a bit early to get Mom ready, was a little late. And when I got home from yoga and my sister wasn't there anymore, and I knew when I walked in that house what I was going to find, and sure enough, my mom was so mad at both of us. She really acted like an adolescent child. She went to bed. She said she wasn't going to get dressed and wasn't going to come to dinner. And my sister had to really work hard with her to get her to get up and, you know, go in the shower and get dressed. It really was like dealing with a child, an adolescent. It was, my mother did have pretty severe dementia toward the end.
And you're left with the guilt of being a child who was trying to take care of herself and couldn't do it without issues showing up.
Yeah, and we had to keep reminding ourselves that day. Oh, and the reason my sister was late is because she went to her own workout class. And so we had to keep telling each other, we did the right thing.
Yes,
we did the right thing
good.
today. And, you know,
Very
at the
good.
end of the day, we always felt good about having done what, you know, we took care of our parents. We're proud of what we did. But, boy, you know, we didn't know about care management at that time, and it would have been nice. It was the hospice nurses who, you know, ended up being our rally points, but that was so far, you know, so much later into
a lot of times that's
process.
true. You wait until it spirals down and they're in hospice. And then finally you get somebody who understands your situation. And that's wonderful because they're paid for by Medicare, and we use them when it's appropriate. In fact, we try to bring them in as early as possible because they feel such a wonderful need need in the home. However, it's always good to have that nurse that's standing in the background, the case manager standing in the background, making sure hospice is doing good, your family's okay. It's not that we have to put a lot of hours in, but just knowing that you can pick up that phone on a Saturday and call that nurse and say there's something going on, instead of having to call the doctor or wondering should we go to emergency room, and being able to just have that contact of somebody that you know that wasn't just introduced yesterday, but you've been with for 6-7 months.
Sure.
It's delightful.
What is the expected obligation, if you will, in terms of time? So I call Care Insight, I hire a care manager. Can I just call as needed, once every couple of weeks, once every couple of months, or is there more of a contracted cadence of appointments?
Well, we do have a contract, but the contract says, you know, here we're going to do an evaluation, but then we'll work hourly with you by the hour, right? So depending upon the financial abilities of the family or the needs of the family, because we weren't really rich, I'll tell you, but we had 8 brothers and sisters, and they all said, hey, if it's going to take care of the problem, we'll put in our bucks to manage it.
Helps.
So you can share that with people, but our families really let us know how often they want us there. Now, if they want us to be there at every appointment, then we make sure that we are there and that we can follow up. And we usually make the appointment, arrange for the transportation, and follow up with it. And then we write reports to the family. If our client says, be sure to let my sister know or let my daughter know what's happening, we send emails off as often as necessary, keep them informed, or it might be a phone call, whatever works for the family. We keep them informed, and then they get a log every 2 weeks that says, this is what we did, this is how long it took to do that. But by that time, they should be very well aware of what we were doing if they want us to stay in touch with them.
Great, okay. Now, Care Insight grew from another company that you have, Care Forward. Tell us a little bit about the genesis of your getting into the care business in general.
Good. Okay. Well, I graduated from Harper Hospital many moons ago, and I've worked in a lot of areas of nursing. And when I came back to Michigan, where I was born and raised, I got a job being a case manager for people who were injured in auto accidents.
Okay.
I loved doing it. First of all, I love working one-on-one with people. And I like being able to see people when they were not doing well and all the way through their recovery, which allowed, you know, our auto no-fault insurance in Michigan allows you to have a case manager if you need it for free, for no cost, if you're injured in an auto accident. So I started that business in 2001. And in 2008, we had already had 15 care managers throughout Michigan, and they were saying, Deborah, I'm getting up there in age myself, but why don't we start working with the geriatric population? And so that moved us into our second business, which is Care Insight, to care for the geriatric population. So if people have an auto accident, they can call us, and we will show them the way.
Right.
And geriatric is also the second business.
Are they separate staffs or separate groups of
They are same internal staffs, right? Some of my catastrophic case managers don't do geriatrics, and some do geriatrics, so they do dual duty, some of them, if that's what they love.
Okay, all right. And you're all over Michigan.
We are.
You cover the
pretty
state.
much Grand Rapids and Alpena area we have a hard time with. And the Upper Peninsula. But other than that, we're pretty good. Yeah,
very good. Well, tell us a little bit about yourself, Deborah. How did you get into nursing in the first place?
Well, when I was going to school back in the 70s, you were either a teacher or a nurse, right? And I was raised in a very religious household, and I loved to travel. And I was going to be a missionary nurse because I got to go to South America and Africa and be a missionary nurse. Well, I got into nursing school and decided, no, I don't think I want to be a missionary nurse. I just really want to travel. So I did. I spent 15 years after I graduated from nursing school traveling all over and working in different places. And I loved it. I absolutely love nursing. It's been a passion of mine, and I love working with a group of nurses that really I was just thinking the other day, the difference we make in people's lives. You know, when you're doing something, sometimes you can't see the forest for the trees.
That's right, that's right.
Every once in a while I stand back and I look at the nurses I'm working with and the situations they're in that they masterfully handle and really help people and ease people sometimes in the toughest areas of their life. And they use their skills incredibly well to help people's lives be better. And I just love being witness to that.
Yeah, that is amazing. How do you find your nurses?
They need to have 15 years, 10 to 15 years experience in nursing.
Okay.
So they come to me with the nursing skills. I don't teach nursing, but I do teach case management and care management. So to hone those nurses into delivering their services out in the community and adjusting them to the situation they walk into. Because you can imagine we walk into many different situations. And to be able to be flexible, I call them willow trees, be able to go just about anywhere and make people feel comfortable, make them feel safe, and move them forward, even if sometimes it's a hard thing to do. But you have to be patient. You know, you move a half an inch, sometimes it's as much as moving a foot.
Right.
You just move forward as much as you can and work with the individuals so they trust you.
Right.
And trust is a big part of our business.
It's so much about relationships,
It
isn't
is.
it? Yeah. So we'll give your telephone number again in Michigan, 248-331-1000. And your offices are?
In Southfield.
In Southfield.
Thank God for Skype and electronic medical records and conference calls and video.
You're
amazing.
You're talking to families probably all over the country, maybe all over the world.
And we're actually in Florida now. We're actually in
Right.
and Tampa area, taking care of clients in that area. It's really quite amazing.
Oh, that's a fairly new move for you.
Yes, it is. Yes.
Wonderful, wonderful. So people who either live there permanently or move from here for snowbirds.
Right. We can follow them.
Your folks are there as well.
Yes.
That's great.
It is.
We've got, I think, about a minute left. Anything that we haven't touched on that you'd like to close with, Deborah?
People can just call and talk to us. Right, so we always say you have my attention for at least 30 minutes. You may have to get through Michelle, who answers the phone, but she'll put you in touch with me, and you can ask me any question that you need. Will we make a difference? If this is happening, can us interceding make a difference? What might it cost us as a family? I have a great listening ear, and I'm able to sort of put two and two together, and if it's not us that can help you, I know someone in my network can. So I can give you different people to network with if we don't have the answer for you.
That's great. Well, you are right. You do have a great listening ear. In the couple of years that I've gotten to know you, it's been terrific. You've been a great resource for us as well. So
thank you.
Thank you for coming over to the East Side to be on our show, and we hope to see you again soon.
Thank you so much, Anne Marie.
Well, we've come to another conclusion of Aging Well in America. Thank you for joining us. We look forward to seeing you next time.